I don't know if he can connect.
Hello, hello, doctors. Dr. Amir, can you
Hello,
hear me?
hello, Dr. Azhar. Nice to meet you.
Nice to meet you, Dr. Amir.
Thank you to accept our invitation for presenting this exciting topic. I really am grateful to have you today. And also, we have Dr. Farid. She is, like you, a prosthodontist and also an implant fellowship. We have her in our fellowship programs for the postgraduate students. I want to say hello to Dr. Farid. And Dr. Azhar, we can start your presentation.
Okay, okay. Thank you, Dr.
Yeah,
Amir.
yeah. Let's go for it. Yep.
Okay, I will share
We have
my.
about 1 hour, and this is a series of webinar regarding the collaboration between Tehran University of Medical Sciences and University of Airlangga, UNR. This is a very prestigious collaboration. We hope to keep this kind of cooperations in future, inshallah.
Inshallah.
Okay, we are all ears to watch your great presentation and learn from your knowledge, dear Dr. Azhar.
Dr. Azhar.
Okay, may I share my PowerPoint now?
Let me check. Uh-huh.
Can you see my PowerPoint now?
Yeah, it's a little bit with delay, but right now I can see your presentation. Please make it full screen.
Oh, okay, okay. Okay,
Uh-huh. Now it's good. It's good. It's with a little bit delay. I don't. It may be because of the internet, but we can see your slide. This is the first slide, and please go on.
okay. Thank you, Dr. Amir. And good afternoon, everyone. Uh, Today, maybe I will presenting about topic in implant dentistry. Maybe this is the procedure after surgery. We can see that after surgery we have many accessories for implant. But actually, I don't know what kind of implant system is famous in your country. But I try to give some example that is very common used in white wolf. So we know that we have many thing accessories from implant after like a surgery. Actually, from the simple one until the advanced one. Maybe there are we know that temporary abutment and multi-angle abutment also. Sometimes if we want to make a removable implant prosthesis, implant supported over denture, maybe we have a locator and then we have a start port and many others. But in this session, I will try to sharing about the simple one. Maybe we have healing abutment and then abutment, abutment and how to make the impression and until how to select the cementation in the restorative implant dentistry. So as we know that the common we can use is rigid or plaster abutment. It is very simple in implant dentistry. When we have a single tooth implant, we can use this one. And then this is the something of the some kind of how to accessories that we can use. But in my opinion, I for me, I cannot remember what kind of accessories that I have because this is very too many component. Sometimes I must make a documentation. What can I use with this patient? And sometimes I just tell to my assistant that I might have healing abutment with the hey this one something like this one. So we have many various component in dental implant. We know that this is the little things in our clinic. If we have falling in floor, maybe it's very difficult to find the something accessories. That's why, especially the screw in the titanium temporary abutment. This is very difficult, and we have multi-unit abutment where it is fall in floor. We have very I'll always yeah, okay, it's loosening, it's loose, maybe we have the others one, but today I don't talk about that. uh I want to explain first about the implant impression technique. And we know that the accuracy of impression making is a crucial step in the successful dental implant, and it is play a vital role in the implant, especially in fully and partially edentulous patient. The study have shown that lack of passive teeth can lead to various biological and mechanical complications. This including maybe screw loosening or maybe bone fracture or maybe occlusal mismatch, and all of which can compromise the implant successful. Therefore, the precision of the impression taking is very essential to achieve proper fit and long-term successful in dental implant restoration. And when we're talking about impression for fixed prosthesis over implants, we have several kind of factor influence accuracy. The first is impression technique. Yeah. Impression technique is play a role, critical role. And wherever we use an open tray or closed tray technique, we can impact the final fit of the prosthesis. And the second, we have a consideration about impression material. We must be choosing carefully. The different materials have the varying level of the accuracy, flow, and dimension stability. And the third, we have the number of angle of implant. It is very important. Can we affect the impression process? The multiple implant or the implant placed at the angulation may introduce distortion in if not properly managed. And the last, finally, we have implant placement depth. It is another crucial factor. Deeply placement implant may require the spatial technique to ensure the accuracy of the implant. Sometimes when I have deep placement in my patient, uh, I already prepare the titanium temporary for making something impression to help us. By choosing this factor, this four factor, we can improve the precision of the art of impression and enhancing the long-term successful of the implant supported prosthesis. And when we're dealing with the multiple implant cases, achieving the best result, we can choose the most suitable implant technique. However, this single best, there are no the best technique in every technique in implant impression. The method applies depend on the case. The goal is the impression is to ensure the minimal discomfort of the patient and while achieving the highest possibility of accuracy. We know that the accuracy is very important to take an impression. And currently there are three kind of the technique of the implant impression. The first one is the direct impression technique, or maybe we can know that this is the open tray impression technique. And the second, we have the indirect impression technique. And first, as the close tray or the transfer impression technique. And the new one is we have a digital impression technique. And digital impression technique is which utilize the advanced scanning technology for the more precise and the more comfortable of the patient. And this technique has its own advantage and disadvantage. Every type impression always have the edges, and it is chosen by as the clinical situation and the desire of the outcome. And now I want to talk just a little bit talk about direct impression technique, or we know that the open tray impression technique. It is a widely used method in implant dentistry, and in this technique, the impression post is the severely attached to the dental implant. And a key of aspect to ensure accuracy is the impression post must be longer than the body of the screw. This allow proper engagement and prevent the distortion of the during impression removal. And as seen in the image, the essential component of this technique is including a screwdriver and an impression post and impression analog and the impression material also. And this technique provides the high accuracy, especially in the case of the multiple implant. Yes, especially in the multiple implant and multiple angulation. And is as it uh, capture the exact position and the angulation of the implant, which is in the our arch of the direct impression technique with the with and method splinting as the study by Martinez Ross et al. And on the left picture, we see that the direct impression technique without the splinting, and where the impression posts are placed and individually without any rigid connection between. And one of the right side, we observe the splitting are joined using the selection acrylic splint, or maybe we have the dental floss with using the composite or using the acrylic. It can be used also, and plaster customize the metal bar. The study concluded that the splinting technique provide the greater accuracy compared to the non-splinted. And this is because the splitting can minimize the potential of distortion and movement of the impression post. And which can lead the error final basis. So if any implant placement in our patient, maybe our on X patient, and if we use direct impression technique, it is better to make a sprint we can that is have a screw into the implant to capture the impression. And once the impression material has polymerized, impression post remain attached to the implant. The impression post is then detected from the implant and connected to the implant analog. Model fabrication. And the advantage of this technique is and and we can use this one. However, it is important to note that there is risk of distortion when the repositioning of the impression
I can't hear anymore.
Dr. Azhar, we do not have you on the room. Please, if you can, join again. Dr. Farid, you have my voice, yep?
Yeah, I have your voice.
Okay. Waiting for Dr. Azhar and Dr. Nadia.
Yes, Doc. I'm sorry. Please
I
kindly
have you,
wait a
yep.
moment. We,
Uh-huh.
Dr. Azhar have the connection trouble.
And if we can change the connection of Dr. Azhar, I think it
Yeah,
was
yeah.
a little bit slow.
Okay, okay. I got it. Thank you, Doc.
Yeah, we wait, we wait.
I'm sorry, Dr. Amir.
Okay, okay, we have you again. Thank you.
My connection is, I have a poor connection in here. Okay. May I continue this slide? And
Yes, yes.
yes, okay, thank you. Okay, in this, I will continue my slide in this stage. After we take an impression, the assembly component are carefully positioned in the matching of the negative creating by the impression point in the impression material. And this step is very crucial. We must make a marking in our lab analog and pick up for the pick up impression. And this is the crucial step, and we must ensuring the step the impression post and the implant analog are placed in the strictly in the right position and maintain the accuracy for the fabrication of the final prosthesis. Any misalignment in this stage can lead the discrepancy in the final restoration. And therefore, the meticulous attention should be given when the transferring the impression post and the analog to the impression to avoid the error and could compromise the fit and function of the prosthesis. So I must placing myself because I don't believe the lab for the placing of my impression analog. And then in certain clinical scenario where the mouth opening is resisting, such as when the implant position far from in the mouth, within the mouth, and the direct impression technique can be challenging due to the length of the impression pause. Additionally, the patient with the strong gap reflex, maybe for the example, we can might find the direct technique uncomfortable. It's just the case, the indirect or prostate technique won't become the preferred alternative. And impression materials around the impression pause, enhancing support the ensuring the more stable impression, leading to better accuracy in the final prosthesis. And the indirect impression technique is the particularly beneficial in the specific clinical situation, and maybe it is the indication for the indirect impression technique when we have the patient has the limited mouth opening, or when we access of the implant is in the posterior area is challenging. And the second one, there is the implant intra-arch space, making it is difficult to manipulate the impression component. And then the third is if our patient have the extra gag reflex, making conventional impression technique is uncomfortable. And the last, if the case involves the pure and the parallels of implant is so good, where the indirect technique provide the sufficient accuracy and the easy to use. By selecting the appropriate impression technique, we can enhancing the patient comfort and then improving clinical effective and while maintaining the accuracy of the prosthesis. And the last, we know that currently there are two primary techniques available in digital impression, and digital impression is developing in wide world, and especially in my country in Indonesia, the using of the digital impression is very famous in here. And the first technique, we have two kind of the impression, digital impression. And the first technique capture image as digital photography using direct such as the Tero, Lapa, and it is not common use. And the second one is the technique that using the digital video scanning, which is providing the continuous and dynamic capture in the oral structure. For the example that this is common we use, maybe we have the receive, pre-op, medit, carry stream, signing, 3M, and many others. And this technology enhancing the accuracy, but every technique have the limitation. Maybe we have more than 5, the accuracy of the digital impression is very decreased. So we have make a consideration what kind of the impression that we want to take in our patient. But this technology with using digital impression, this technology give us the accuracy, improve the comfortable of the patient, and then streaming of the workflow of dental professional, and then the last is saving time for us. And for the after that, they have the CAD/CAM after we take the impression by digital or CAD/CAM system. There is the role in modern dentistry. We know that, and the system consists of the 3 main components that work together to create the precise and effective dental restoration. The first one is the data acquisition unit. This unit collects the digital impression from the intraoral patient and the other structure and the adjacent structure, and it's convert them into virtually impression, which can be obtained directly and indirectly using optical scanning technology. After the second one, we have the specialist square. Actually, if we the conventional methods, maybe we can use the waxing and many others for the make a design. But now we have the specialist software. Maybe uh, the famous one is maybe Exocad. We can use this or the make a design for this our restoration. And the final, we have the computerized milling device. After we have something like design in the Exocad or what else, we can just send in the milling machine, and then we can directly make the fabrication of the restoration. So this is very simple and saving time for our treatment in our patient. But we know that the CAD/CAM technology enhancing efficiency and improving the patient experience and provide highly accuracy, but is you know that this is maybe pricey. Yeah, I think this is more pricey than we have conventional methods. And the digital is taking using for the implant workflow. We must have the scan bodies. We have scan bodies with connected with our fixture when we want to capture the extra position of the implant. And this impression also record the surrounding tissue and the hard tissue. With this data, digital model is created and allowing for the precise evaluation and the planning. Maybe I have some video that we can see the how to work with the implant. Maybe after this is the video about the surgery. Maybe the surgery is common. We can using the workflow in the every system that we can use. And then maybe I can firstly, maybe after surgery, we have a selection of the healing abutment type. What is the height of the healing abutment that we can use? 3, 4, or 5, or 7 maybe. We can use various length and the various of the diameter of the healing abutment, and then we can placing this one. And then after this, we can remove the healing abutment and we can select the abutment. Maybe forgive explain about the impression. We have maybe I can we can make the impression with the abutment level or implant level. If we have the abutment level for the impression, we can just directly impression something like natural teeth of the front end bridge. We must make a impression before we placing the healing abutment, and then abutment. Also, we can talk with 35 Newton meter, and then we can directly impression with our patient, and then when we I explained before, we have the closed tray technique and then open tray technique. This is the illustration of this one. Maybe this is the closed tray technique. We can select the impression analog for the big up, and then we placing the impression material. Maybe we can use line body or maybe regular body and body. And then we have something like marking or the indexing of this lab impression analog. And then after this, we placing again the healing compartment, and then we can make the dental laboratory procedure. Now this one is we can placing the lab analog in our impression, and then we casting the model with the chip soup. And this is for open tray pickup. We use tray that we have hole in this tray. This method we can use for the parallelization of the implant is not the same. Maybe more 30 degrees more in the book bottle, maybe in the lingual side for the during surgery. It can be used because we cannot make but the parallelization of this implant. And then something like cluster technique, we can connecting and placing again in our impression. Okay, now how about the suprastructure in our implant? We know that I will explain the concept of the cementation of this restoration. And this technique have involved the placing dental cement inside the restoration for the connecting crown and the implant fixture, which is the position of into the titanium abutment inside the patient mouth. One of the main advantages of this method is the easy to placing if we have a cement technique. But the using of the cement in the implant dentistry, it can be potential and can lead of the peri-implantitis inflammation. And before the processing with the cementation process, we must the preparation of the essential for the ensure on the best clinical outcome. And the first step is we must to try in its restoration individually, and this allow us to check the marginal integration, ensuring that there are no gap, misfit between our every restoration and the abutment. And proper marginal seal is crucial for the long-term successful of and preventing of the micro leakage. And next, we should try in the restoration correctively into access of the proximal pin. And this step, we can ensure that the adjacent restoration and the position of the restoration is the correctly, and then there are no interproximal gap or excessive access to contact. By carefully following this preparation step, we can optimize the fit and the function, longevity of the implant restoration or implant restoration. And what can dental cement we can use? The first one is the oxide ethanol, maybe GIC or RMGIC, and resin cement. Yes, it's every material have the advantage and disadvantage. Actually, commonly I use the GIC or resin cement. And how about the others of the cementation? If we don't use the cement, we have the screw retain prosthesis. The screw retain prosthesis is one of the two type of the implant supported restoration. If we have the screw retain prosthesis, we must make a consideration of the aesthetic and the occlusal consideration. And one of the key of the factor to consider when we take the screw retain prosthesis is the screw access hole, while the exposed in the occlusal surface, it is okay. And this is can impact the aesthetically if we have the hole in the labial side, especially in the anterior restoration. And the second one, if we have a screw retain, we can easily retrievability of our restoration. And a major benefit of the screw retain restoration is that they can be easily removed without we must make a distortion in our restoration. And this is very necessary, and we have maybe control our patient in following control in the next year after the insertion of this restoration without the wrist accessories with the cement. And then this is maybe for the just screw retain, it is challenging of the fabrication, because the error may be occur during the casting and or the firing process, where can affect the accuracy of the prosthesis. Proper technique and quality control are essential in the minimize of the issues. And maybe I have some video about the how to make the screw retain, just screw retain, not the combination. Okay, I will skip this part after surgery. Now, if we want to make a screw retain, we have component. The minimum component is we have the minimum interarch every implant and the antagonist. So we placing this part for the connecting with the implant and the but this is something like abutment. We can connect it directly with using this one with the our restoration. And it have the several size. It's depend on our keeper placement of the fixture. After we select the apartment, we take an impression. This one is open tray transfer impression. And we make put our impression and connecting the left analog, and we can tightening again. Okay, and then the fabrication is start from here. Actually, in our country, this is not common use screw retain because we have combination. The combination is the most popular in here, and for me, the combination is my favorite restoration for our patient. But if we have something like the minimum cap or minimum access for the antagonist attendulus in our patient, it can be one of the alternative for our restoration. So after placing the abutment, we can placing the something like if we know it's like TI, but it's not for TI temporary, for permanently, and then we make the cost for our crown, and then we can fabrication using maybe an ECR, also ECR, or maybe zirconium. So this is maybe the directly abutment, and the crown is in one piece material, and one piece of the part of this restoration, and then we covering it using ceramic or maybe zirconium layer. And then we tightening with the pressure in 35 Newton for the insertion. Okay, the next is maybe the cemented. Cemented is this is maybe we can use it easily because it is something like a natural teeth. The fabrication process, unlike the screw that before, the cemented processes are cast or firing separately from the abutment during the fabrication process. They are then permanently secured with the cement, ensuring the strong bond. For the aesthetic, it is very we can get the aesthetically likely. This is the one of the biggest advantages for we can using cemented. And the challenging is for removal. It cannot be retentivability. It is the disadvantages of the cemented. However, the one of the major of the disadvantages is the removal of this crown is so very difficult. Maybe just we must make a destroying of the cement restoration. And another issue is for the cemented is excessive cement. So excessive cement can be difficult to clean, and this is increasing the risk of the peri-implantitis inflammation and the other complication. Proper cementation technique are essentially to minimize of the risk. And then the others one of the advantages of the cement, we can get the passive fit setting, because the passive fit setting is very uh, we can, what can I say? I can get more passively setting. It's very important for our restoration, because with the special benefit of the passive fit, it can if we cannot get the passive fit, it can lead the something like screw loosening or the fracture and the others. Yes, that is the cemented technique. Yes, after we select the apartment, uh, this is the step in the laboratory. Maybe after we select the apartment, we can make a front separate in the apartment. And then we can placing the apartment first for in the patient, and we can get the tightening in the 35 Newton, and then we placing the crown with the cement. Yeah, maybe it is easily. It's like we can make a crown and bridge in the natural teeth. cementation in this. And now we have the combination. We have the combination, maybe STRP, I think. We know that the screw cement retain prosthesis, this is the combination between the cemented and the screw type. Actually, this is something like cemented, but before we make a tightening, we can get the retrievability of the restoration, and we can easily remove the excess cement. The fabrication is the similar with the cement retain, with the casting or firing separately from the abutment. However, it is incorporated of the screw for the easily retrievability. And the one of the consideration we must select this one is the screw hole consideration. If the screw hole in the aesthetic area, I always make a consideration alternatively using the cemented one. And this is the easily to maintain. It is the one of the biggest advantages of this implant. Yeah. In this maybe for the STRP combination, they have the benefit of the both screw and cement retain, offering easily retrievability, reducted cement complication, and the passive fit. We can get this one. But we can get the passive fit only when we cement it in the clinic, because sometimes in the dental laboratory have the offering that doctors, could you send cement this part with using the abutment in the laboratory or not? I always choose I cemented this part in the mouth of the patient in my dental clinic when patient come, because I must get the passive fit. The passive fit is very important for our long term. Maybe this is for the example illustration, CRP. This is okay. Maybe I skip this one because the limited of the time. Yeah, the very important things is the hole. Hole, we must make the position of the hole in the non-aesthetic area. After we placing the abutment, we can cementing, and then after cement, the settings is we can get setting in the cement. We can open this material, and then we can remove the excess cement, and then after the screw is good, we can tightening again with the 30 until 35 Newton centimeter. This is my favorite type of our restoration. And then maybe I can resume this step by step for the implant procedure. The first one is the implant site preparation and the healing period. And then before we can get the proper LC integration first, and then we move abutment selection and the customization. Maybe we use custom abutment. And custom abutment is very important, and it have many advantages for us. Now maybe some patient I have custom abutment, and then for custom abutment, it's very necessary for the better tissue adaptation and the restoration fit. After this, we take an impression and dental procedure, and then try in adjustment and the cementation procedure, and then the adjustment. Yes, this is the workflow of the implant workflow. In image A and D, the placement on the healing period, and then the C and D, we can take a digital impression for our patient. And for image E, we must prosthesis component application, and then process try-in and cementation in image F and G, and then we can evaluating the placement of our implant. And okay, how about we can choose the cemented retain or the screw retain? It is very difficult or not? Maybe it's depend on placing of the implant fixture. We have some criteria for the selection of the restoration space. The first one is the retrievability space, and then the second one is the restoration space, aesthetic, and the parallelism of the implant. This is four type of impression selected criteria for we choose which one for the our restoration implant. The first one is restorative space. The restorative space refers to the occlusal gingiva. Occlusal gingiva, height of the edentulous span, and which will be the occupy of the culture crown. If we have restoration space with the minimum height, maybe for the cement type, the minimum abutment height needed for the cement retention is the 4 millimeter. Because we must make a consideration in our material of the restoration. Maybe it's around 1.5 until 2 millimeters. So if we have 5.5 millimeters in the occlusal until the antagonist tip, we can use the cement type or maybe in the SCRP screw combination. But if we have the less space needed as abutment as the single crown and one piece implant, maybe the minimum criteria is 3.5. We can use the screw type because it is very thin, and we must curious about the retention of the cementation. So if we greater than 5.5 or both, we can select both cementation with the cement on the screw type or the SCR base. It's very free of us. But if we have just 5 until 3.5 millimeters, we make consideration using a screw type only. And the second one is the criteria is the retrievability. And we know that the retrievability is to ability of the retrieve of the prosthesis is the very crucial, very crucial for the maintain and repair, and then the modification. And the screw retain restoration offer easily retrievability compared to the cement retain of the prosthesis. And as we know in this picture, for implant restoration in the aesthetic zone is the very crucial aspect of the implant dentistry, and this is require the precise and the planning and execution. The key consideration for the aesthetic zone implant is the implant positioning. The proper 3D positioning is very essential of the achieve the natural emergent profile. The placing of the implant to buccally or maybe to lingually, it might make a gingival recession of the aesthetic the failure. And then the soft tissue management is very important. And the third is material selection. We know that the zirconium or lithium disilicate is offering excellent aesthetic, better than the porcelain tissue metal. Maybe sometimes the using of the pink ceramic maybe have the compensation of the soft tissue deficiency in this area. Or maybe in periodontic department, we can keep something connective tissue brush. Maybe it will be better. And then for the prosthetic consideration, if the hole in palatal, the proper position, ensuring the optimal screw access is reducing the risk of the cement retain for the periodontitis. If the hole in the palatal, we can use this type using screw retain or using this SCRP. As well, the position implant facilitating in the aesthetic is very important. Besides the functional. So, how to get the precise of the aesthetic area? If we want to make the predictable position, the guided implant placement is the one of the answer of this to challenge of this result. So guided implant placement involving the using of the surgical guide or maybe now the dynamic guide navigation system to ensuring the precise position of the implant placement according to the pre-plan in our planning in paper in the digital design. The advantages of this guide placement is the enhancing the accuracy and precision, and then the 3D surgical guide ensuring the implant is placed set in the ideal position and the good angle and the good depth, and then the reducing the right risk of the misalignment of the improper angulation, and then maybe we can using the flapless so we can the minimally invasion approach. And last, preserve the soft tissue and bone structure because we not make incision in this soft tissue. So retrievability. Okay, I will discussing about the importance of the retrievability in implant dentistry. So why we choose the screw retain of the SCRP? Because it's offering preparing for cementation retention in the site. Why the retrievability is important? Because this is very crucial for the long-term maintaining. Because we want our patient, our implant patient, have the implant successful in the 10 years, 20 years, and until the end of our patient. So we need the long term of the maintaining and the repair and the modification of the implant supported prosthesis. So if the complication arise, such as maybe the screw loosening or maybe fracture or maybe the periimplantitis, it can easily remove restoration, allow for the non-invasive correction without the damaging of the implant or the surrounding of the teeth. Yeah, this is advantageous consideration. We choose the retrievability, and then the third one is the aesthetic. The aesthetic one is the very challenging. So our consideration, the whole, if the in the labial side on the on the occlusal side, we can make choosing the others. Why? Maybe the cemented is better for the aesthetic one. This is our consideration. The screw hole access. And the last is the parallelization of the implant. okay, if we have the just one placing implant, is we can using free for us. But if we have the 2 or 3 or 5 or in all on case, we must make a consideration how to make a parallelization of this implant. And maybe the sprint crown is more we can choose the split crown retain because it's more better than the single. And for correction and the non-parallelization of the implant for the screw type, well, the screw retention restoration offer the advantages in the term of retrievability and the maintaining of the implant. We can get the position, good position. But if we not have the parallelization, we can make difficult for us, or especially or prosthodontic, if something, if the surgery is not us, the prosthodontic, and then refer the restoration from insertion in prosthodontic. This is very difficult to get the insertion when the parallelization is not good. So maybe the choosing is the cementation, for using cement in this position. And maybe for this picture, the solution of the parallelization, if we have some patient with full mouth rehab, or maybe for on 6, maybe this is the something workflow when we need the cementation. And in this picture, the honestly, this is we can get the parallelization with a good position, but if we don't have the good position, maybe we can make it separately, or maybe we can get add the number of the implant, so we can make a separately for the just anterior and the posterior set, and the labial set and the premolar set. We can get separately restoration. This is the workflow for this resume of this our presentation about the screw and cement. Okay, maybe the advantages of the cemented and the screw type, as like I mentioned before, that we have a cement type. Maybe the advantages is the familiar aesthetic. We can get the aesthetic and then get the non-accuracy impression, and the not parallel implant is okay. But for the advantages for the screw type is the key can reducing the space, and we can get retrievability and no cement. No cement, it means we can mention that we not we need not worry about the excess cement because it can lead the periodontitis if we don't have the good soft tissue in around the implant. And for the disadvantages is the excess cement, for cement retain, and then not retrievability. And for screw cement as an aesthetic paralysis system, and the difficult to achieve and the increase laboratory. Because I want to headline this one, the excess cement can lead the periodontitis when we don't have the good retains soft tissue in the around with the implant. So we must take carefully if we want to taking the cement type. We can make our patient good, not did don't have assessment in our patient. Okay. How to manage the assessment? Maybe we can using the upper dam, or maybe for me, if I choose the assessment, I always give a pull in the palatal side, maybe in the area, non-aesthetic area, for the flow of the my cement over in the restoration. And then I have the case in the one case, the female 47 years old want to placing implant in the maxilla left and the right. And as we know, in the radiographic, we have residual teeth in this region, and I choose make this one in the immediate implant placement. Before that, I make a planning for the implant position in this patient, and then I make a surgical guide. And this is the for region 1.5.1.4. I make a immediate implant placement using this implant picture. And then for ratio 1.5, this is I using 3.6. And for region 2.5, I use immediate implant placement also, because the residual. And then when I did surgery, I got the surgical guide, and then this is the result of this implant. And we know that in ratio 1.4 and 1.5, this is not parallelism. I cannot get the parallelization, because when I did surgery, I must take place same with the teeth after extraction. And then I make an impression, digital impression. After that, I make a design using ExoCAD. In the software, I can get the parallelization of this implant, the axis of this implant, which one this is my consideration. I can use cemented or maybe screw type. And this one, I make a splint crown in one regio, in regio 1.4 and 1.5. Okay, after this, after the fabrication, insertion of this patient. Yeah, this is the consideration when we get the cementation in the one regio. I use this cement type, and the second regio 2.5, I use the screw STRP screw combination. For the second case, female 46 years old, want to place in just in her right side, because in the left side they have the removable partial denture. But I try to explain the patient, maybe after this they want to change the removable denture with the implant also. But in this case, I just placing in the right side. And we know that there is the residual teeth in 1.5, and this one you can get the limitation of the sinus flow. Make the design first with the prosthodontically consideration with this region. Okay. And in 1.5, I placing this one, because the limitation of this region for the diameter, and 6 for the length. And then for 1.7, unfortunately, I must make a sinus lift first because this is the limitation of this sinus floor. So I did the sinus lift first in this region. And in the mandibula, it's okay. It's not it's very easy. It's quite easy. But in this in region in 447, we have the recession in this area. So I did the surgery, and then I did the sinus lift in the lateral approach first, and then in the lower I open flap because I must the correction of the recession of the adjacent region. So I placing the bone graft also in the end membrane. So this is the result of the surgery, and then I placing healing compartment, and then I scan with the intraoral scanner and the scan body, and this is the result. I make the design for the restoration in the upper jaw. I made the bridge supported implant. Because in this area, I can get the paralyzation of this implant in region 1.5 and 1.7. So I make it using the combination STRP. And I make the apartment with the custom apartment in this patient. Okay, this is for the mandibula region. And this is for the upper jaw. Because the paralyzation is okay, I can get the easily for the insertion in the bridge, this part. Okay, and this is the result of the patient. And that's it for me. This is the end of the presentation. If you want to ask something, you can ask directly for me. You can directly message in my Instagram also. It's feel free for you. Thank you. Okay, Dr. Amir, thank you very much.
Okay, thank you, Dr. Azhar. I really enjoyed your presentation as it was kind of really comprehensive. You mentioned everything and you went through the details, and I really enjoyed from the first that you mentioned about the conventional impression taking, the digital impression taking. You mentioned about the overall workflow and about the suprastructure, cement retained restorations, screw retained restorations, and screw cement restorations, as you mentioned about the combination restorations. And I, as a periodontist, I really believe that the success of a dental implant depends on both the surgery part and also the prosthodontics. And these two are not departed. The combination of these concepts helps us to get to better results.
Yeah, that's right, Dr. Amir.
Yeah. And thank you. Dr.
Thank you.
Farid, I just wanted to ask you that in Iran, what do you prefer? Because Dr. Azhar mentioned that in Indonesia, he prefers to perform a combination or a screw cement retained restorations. I don't know, what is your preference and what is your basic or everyday practice that you do regarding the yeah. Thank you. Yeah, go on.
Actually, in Iran, I think we have a problem with sitting after cementation. You know, because when you make something a screw retain, the path of insertion could be different from what you cement over it. So making something that is made for cementation and then you want to screw it, make it, sometimes it interferes with complete sitting. As doctor said, I think they have perhaps they remove from proximal surfaces to sit prosthesis completely. Is it correct, Dr. Azhar? Is it you remove from
Yeah.
because
When I use combination, you mean? Yeah,
what?
Yes, yes.
when I use combination, the first I make a tightening in
Mhm.
30 Newton, and then I cement. I make a blocking in the hole first using the apa what Teflon tape, and then I placing the cement in the restoration. After that, after the setting cement, I I pull out the the front and the abutment that connected in the abutment, and then I clean up the excess cement. After that, I inserting again using 35 Newton, and then I
Don't you,
block with the composite.
excuse me, don't you have any problem with sitting after you cemented it over the abutment and then you want to screw it? Don't you have any problem with path of insertion? Because we have here.
Hey, put in back again after the cementation, you mean? Okay.
Yeah, after
Uh,
cementation, you want to use a screw retaining because cementation, sometimes the path of insertion for cementation is different from what you have for a screw retaining. We have such a problem that, and we should remove from proximal areas to seat the processes completely with the abutment and so.
my consideration is the paralyzation of the implant fixture. When
Yeah.
I done the paralyzation of the implant fixture, I don't use this screw retain of
Yeah.
the combination
Yeah.
because
So
it's
if
very difficult to get the inserting of this part.
yeah, if everything is ideal, yeah, this is a very good approach. But sometimes or perhaps I should say that most of the time everything is not that much ideal, and we have some inclination of adjacency. Sometimes the implants are not completely parallel, or they are in different position from anterior posterior or buccolingually. So it makes it a little bit difficult to use a screw retaining without actually reduction from the proximal surfaces. But yes, we use it if it is a good approach. We use it. A screw cementation in Iran too. Yes, we use it. May I ask another question from you? Do you use yeah, sorry, I'm at the beginning, starting. Do you use scanners in full mods implants? If you have full
Yeah.
mods implants,
If I have the full mode rehabilitation in my patient, I using intraoral scanner.
and don't you have any
Or
problem with it, especially in lower jaw?
ah, especially my problem when I try in the farm, I plan the all on exit using the uh, 4 or 5 implant, I connecting with the titanium bar in each other implant, and I must try in first using the resin bar. When I placing try in the resin bar, maybe one hole or two hole is not uh, correctly in the right position. This is my
Yeah,
problem.
yeah. It
So
is
I
somehow it's still
must
difficult.
separate this resin bar, and then I placing with the corrected position, and then I use the flow resin composite, flowable composite for the connecting the bar in the good position, and then I deliver in the lab, and they can get the disposition for the makeup bar.
So if you want to use full mouse scanning, but especially for the lower jaw, you connect the implants to each other.
In the lower jaw, the limitation is the saliva also. And when this my assistant always make a suction for the saliva in our patient, and then I make a neural scan. And for what kind of the scan body that I use the scan body for the maybe I use the scan body for the bridge, so I can connect it of all
Yeah.
of this implant. Yeah.
So
that
you
one.
use something, some accessory rings to and connected them to the scan bodies to completely scan the whole jaw.
Excuse me?
Do you use some accessories that are attached to the scan bodies to make it possible to scan the whole jaw? Yeah.
I use
Thank you.
accessory for the making impression in the bridge.
Yeah. The last question. Sorry, Dr. Raee. May I
Yeah.
ask the last question?
Oh, okay. Yep. Actually,
Yeah, can I ask, what kind of cement do you use for cementing zirconia crowns to abutments, not tie-based abutments, ordinary abutments, or custom-made abutments, not just tie-based abutments?
I use three kind of cement. If for zirconia, if I not I have some curious with my restoration, I use the zinc oxide equinol first, and then I make appointment for the with the patient in when 1 month again to evaluating. But if I can get the passive fit is okay, and then everything is okay, I directly using glass ionomer cement, and sometimes I use resin cement.
Okay, okay.
But
So sometimes you use
my
graphene.
popular my favorite is using glass ionomer cement.
Yeah, yeah. Thank you so much, Doctor. Thank you for your very nice presentation.
Misalnya Dr. Farzaneh.
You're welcome. Hope to see you in Iran.
okay. Yep. Thank you, everybody. Thank you, Dr. Azhar. We really enjoyed your presentation. Thank you, Dr. Farid, for your nice tips and tricks. I hope to see you in person, Dr. Azhar, in Iran, or we may join you in Indonesia in future, inshallah. And I should thank to all our participants, especially a great giant thank to Dr. Nadia, as she really tries hard to cooperate and to manage this kind of webinars with TUMS. We will be a really good team. And thank you all. If there is any question, please do not hesitate to ask from Dr. Azhar. Otherwise, we can call it a day. And yep, let me check if there is any questions. Let me check the chat box. Yep. Okay. Okay. Thank you, Dr. Azhar. And we are ready to say goodbye to all you. Hope to see you all in person in future. And stay safe, please, everybody. And
Bye.
also please stay tuned for our next webinars. Yep, we have scheduled our future webinars also in other fields. It really helps us to be linked to increase our network, and we can increase this kind of collaboration in other fields like the research, as Tehran University of Medical Sciences, is really good, like your university, Airlangga, in the field of research. And we have very good researchers. Also, we have a really, sophisticated clinic, dental clinic, and we can learn a lot from each other. So I
That's
should
good.
say goodbye to you all. Thank you, Dr. Farid. Thank you, Dr. Azhar. Thank you, Dr. Nadia. Everybody, bye-bye. See you later. Stay
See
safe,
you
please.
later. Bye.
Bye-bye. Bye-bye.